Morning. Morning, Shabuj. Okay, so we have a few topics lined up. So if there are any more questions, keep put it in the chat box and we'll talk about it. So almost there. So good to see you all back. It's been a few weeks. I've been doing some content work, and also the hospitals are big, because travel has opened up. Lots of patients are coming back in. Our clinics are very busy, so that's good in a way. But we still have to be careful. Okay, it's 11. Let's start the show. It's good to have you back. So as I said, we are getting back into normal work patterns, but we have to take all the precautions of wearing your mask and maintaining social distance, because this virus is going to be around. Although in Chennai it is much more stabler, it seems to be of low, as not as virulent as it was. That's my impression, but I may be wrong. But it definitely, things are much better under control in Chennai, and although the numbers are stable, the hospitals are all managing well, and we're happy about that. I know the number of cases in India are increasing. That's expected as the economy opens up. So it's important that we maintain social distance, wear your mask. Okay, so that's the first message we have to put out. So let's start looking at some of the problems which have been brought up already. So one of the first questions, very interesting, is a tuberculosis. TB is very common in this country, and colorectal disease. So TB in colorectal surgery, I come across it often with people normally present with abdominal pain. Then we investigate them and then find a lump in the abdomen, weight loss, some bowel habit change, sometimes bleeding. So when you do scans and things, you find out typically it affects the ileocecal region. Ileum is the last part of the small bowel, and cecum is the first part of the large bowel. And that's where it's usually present. You can get it in the colon, you can get it in other places, but most commonly in that part. So it mimics Crohn's disease. Okay, Crohn's disease is part of inflammatory bowel disease. We've looked at it before. So there is confusion, and it's not possible to do the if you try to do a colonoscopy and biopsy, it's not very clear. So you have to have a look inside. Normally we do, but you will also when you do the investigations and then you do TB testing and all that. Sometimes all these tests are negative, but you still see this lump. So what we do is we put a camera in, do a laparoscopy, which is a camera test to look inside the belly, and then look for where the problem is. Now, if the if there is no bowel obstruction and and the biopsies have been negative for cancer, then we sort of treat them for TB and test for TB and treat them for TB if they come as an emergency. So the question doctor was asked is somebody who's had TB for the ileocecal removed, and it has come back with another narrowing. So the treatment is, I would suggest that you have to get tested for TB. TB is very common. I know now Corona, everybody is talking about Corona virus. Similarly, TB is again very common. Other non-COVID diseases are very, very common, as we've been talking. So the important thing with these things is when you suspect weight loss, there's a lump in the abdomen, you need to obviously do a colonoscopy, biopsy, to colon ileocecal junction, you can take a biopsy. So it is inflammatory, it's still not clear, then you have to test them for TB, and if it's positive, you treat them for TB, and this lump will disappear. But if this lump is or narrowing is causing blockage and patients are not able to eat or drink, then you may need surgery to remove that bit and join it back together. So the first specific question doctors asked is, what do we do? Somebody post 10 years has developed another narrowing. So it may be a reactivation of TB, which can happen. So then the patients need to be reinvestigated, and if they're symptomatic from it, then they're vomiting and have trouble, then you may have to re-resect it. If symptoms are not too bad, whatever the eating is going normally, then we can retest for TB, and if they're positive, treat for TB again, and then wait and see. Otherwise, we have to remove that bit. So that's what. But it is very common, TB. Abdominal TB again is common, and you will see with TB, when you look at the scans, you get all other lymph glands also enlarged. So that's a diagnostic thing. So that's something. Okay. Now the next question has been about follow-up for colorectal cancer, because a lot of patients have been stuck in their homes and towns and cities, not going to the usual places for where they. For example, some of our patients are stuck in Bangladesh or in West Bengal or out of town, wherever, following colorectal cancer. So colorectal cancer, as we've discussed before, needs at least a 5-year follow-up. Okay, once the tumor has been removed successfully, patients need to be on a 5-year follow-up. The reason being that the risk of cancer coming back is highest in the first 5 years. After that, the risk becomes same as general population. Okay, so it's very important to have that 5-year follow-up. So if you're stuck like in this during this pandemic where you're not able to travel, now I think it's slowly opening up. You may contact your doctor or a specialist via online, because now that's ubiquitous, it's easily available. You can call people or consult with them online. So my case, obviously, specifically to answer the question, you can make an online appointment and then discuss it. Now if you need to do tests, it can be done locally in your towns if you can't travel, and then the reports are uploaded onto the different platforms we have. So I think that's a very good, one of the amazing things that's come out of this pandemic is that the online consulting and platforms and information exchange has become much more organized. The governments support it, so I think that's a very good move. So I think follow-up wise, I think any problem, because it's very important to remember that sometimes travel is going to be challenging for all sorts of reasons. So there may be reasons where you need to be physically examined, but a lot of in-between appointments as a regular checkup, follow-up, reading the reports can be done online, and I think, it's easy enough to book appointments online, the payments can be done online. So it's very simple, straightforward, and there are multiple options available, and I think that's the great thing just come out of this learning. So I think, so if you can't travel, make the online appointment, the test can be done locally, and then the results are uploaded, and the doctors can discuss with the patient and the family, and we can take that forward. Okay, so that's that. So the next question is about perianal fistula recurrence. So as doctor from Baghdad has asked, anal fistulas are challenging problems, right? We discussed it again. For me, I take anal fistula surgery the most serious, because it could be a challenging problem. It can be difficult to treat. The fistula tracts are 1 millimeter in thickness, and there are several challenges with finding the tract. Important thing is to find the root. So what I tell patients is that you'll need to be patient, find this right specialist to do the surgery, have a good explanation, good consultation, so that the doctor is able to explain to you what he plans to do. And if it's a recurrent fistula, you need to get an MRI. MRIs can be done for complex, even first-time fistulas. Normally, straightforward fistulas don't need investigations, an anal ultrasound or an MRI. If it is complex, yes, get an MRI scan and a good examination by a well-trained anal fistula surgeon. If it's a recurrent problem, then you should get anal ultrasound or an MRI scan, and then find the best surgeon to do it. Now, I tell my patients there is a 7 to 10% chance of anal fistula recurrence after anal fistula surgery. If you go anywhere in the world, that is what the literature or publications in this field will tell you. So you need to be very honest. This 100% chance of concoming doesn't exist. And the important thing, as I told you about anal fistulas, is that there are, it involves anal muscles which control your motion. So it is absolutely important that you find a well-trained surgeon to do it. And the track side, the critical bit for the anal fistula surgery is that we need to find the root, and we have to lay it open, or there are a lot of new techniques which are there, which we can we've spoken about earlier. So there's another question. After a right colon surgery, the colon is like a question mark. The right colon, transverse colon, left colon, sigmoid, and rectum. So the question is, after removing part of the colon, it's part of the follow-up. I said we follow it for 5 years. The question saying there is an adenoma seen. Now that happens too, right? Sometimes I've had a patient who there are multiple adenomas in the colon and a cancer. We've removed the cancer and put a clip on one of the adenomas, it was hanging, so it would wilt and fall. It didn't wilt and fall, so that needs to be excised again. But the cancer is all removed, and that's fine. But that's why the first colonoscopy needs to be within 6 months after the operation. So then, if it's okay, then after every first year, and then every 2 years, if it's all okay. If in this case, as we find a small polyp, then we can use the colonoscope to go and remove it through the endoscopy, avoiding surgery. So the good thing about screening regularly post-surgery is that if you find any, because when you find a polyp in one area, you will also find polyps in other areas, because your entire colon has had some change, the lining. So there is a risk there. Now that's why that 5-year follow-up. So if there's adenoma through endoscopy, you can go and burn that. And then that will be the end of that problem. But you still need to follow up another colonoscopy within the 6 months to see if there's anything else, and normal then every 2 years. Okay, so that's how you deal with polyps seen or adenoma seen after a colon cancer has been removed. So there's another question: blood thinner being on multiple colonic diverticula. Yeah, so colon diverticulosis is these are little pockets along the bowel wall. Now, it used to be very uncommon in this part of the world, Bangladesh, India, Pakistan, Nepal, Sri Lanka, this part of the world, because of the diet we've been eating, because we have lots of vegetables, there's lots of fiber. In the Western world, there's lots of processed food, and so the diverticular disease of the colon is very common in the Western world. So diverticulosis. So I remember in my training in England, every week there will be at least one case on the list. Diverticulosis. We have to do a resection of the bit of the colon to remove that and join it back together. In India, it's not, or on the subcontinent, it's not that common, but it is becoming common because our diet's pattern is changing. So diverticulosis are small pockets along your bowel wall, which can get inflamed, can cause abdominal pain, it can change your bowel habit, it can bleed. So the way to maintain it is, there's no treatment, you can't make it normal. The way to deal with it is to have lots of water, high fiber diet, exercise, avoid red meat. These are things which are going to keep your bowels functioning well. Now, if you have more than 2 attacks of abdominal pain, where you need to take antibiotics, or if there's bleeding, recurrent bleeding, and then you may need to have that bit of the colon removed and healthy ends joined back together. So symptomatically it can be treated, but if it's causing recurrent problems, you need to have that bit of the bowel removed by a well-trained surgeon. So that's diverticular disease becoming common. We used to see right colon diverticular more common in Asia, but again we are starting to see more as again people are living longer. So as you get older, it's typically a disease one which you see as people get older. So you get older population, pockets along the bowel wall which can get inflamed, change in bowel habit, and it needs to be investigated. So classically seen as little like a Swiss cheese, holes when you do a colonoscopy, and that's how it looks. So hi Tamina. So CEA levels. What is a CEA level? CEA, carcinoembryogenic antigen level. It's a blood test to monitor patients who had colon cancer, for example. The levels will go up if you have cancer, particularly colorectal cancer. Now usually we don't check it when they initially come in because we know that the cancer has been diagnosed, but routinely a lot of people have it checked. It may less than 5 is normal. Between 3, 5, 6, 7 is okay. If it goes up to 20, 30, 40, 50, that's when you think that's an indicator that maybe there is cancer which is spreading or undetected. So that is used as a marker. So as follow-up normally. But what we do is we do a baseline test at the time of treatment of initial colorectal cancer, and then when you are monitoring these patients, as I said, for 5 years, we need to keep checking them every 6 months because that can be done easy locally, and you can keep in touch with your doctor and updating them. So CEA level. So with treatment, the CEA level should come down, and if it's going up in spite of treatment or suddenly it goes up, then we need to reinvestigate the patient to see if there's anything which we missed. Okay, so that's that. What else will we talk about? Incomplete evacuation. So let's talk about functional bowel colorectal problems. Functional colorectal problems are very common. Functional disease. What do you mean by functional disease? Is where there's not related to colorectal cancer. It's a benign condition, but it's a nuisance. Basically, where patients not able to have a proper bowel motion because of multiple problems. Now, what can these problems be? One, it could be poor diet. We need to have a high fiber diet, a lot of vegetables, a lot of water, exercise. So that's primary. What you eat is what comes out. So you need to do that well. Now, apart from that, what can be a problem is the colon itself can be not working well. Now, that's called slow transit constipation. So basically, the function of the colon itself is not great. So your bowels are not moving well. Other things could be because of the medication you're taking, right? They can have an effect. They can make it loose. They can make it hard. So that needs to be monitored. Sometimes you can have medical conditions like diabetes, where long-standing diabetes can have neuropathy. Neuropathy is when the nerves get affected, and so when you have it for a very long time, so the colon doesn't function well. So it doesn't go. The colon doesn't work well. So you can have loose stools. You can have colon dysfunction. So there are multiple reasons for that. The other reason why you don't have a proper bowel movement is that the pelvic flow could be a problem. Now we've discussed that many times. Now we will talk about that again. The pelvic flow is like let's say a sling. Okay, you have two parts, two type of these muscles. One between your chest and your abdomen, called the diaphragm, which separates that. To the diaphragm, the food pipe goes, and the food pipe goes into and then becomes the stomach. But it goes through a small hole. Yeah, that's the diaphragm. Then in the pelvis level, there is another sling of muscles. Okay, and through the muscles, you have the urine pipe going, you have the vagina going, or the rectum going. So 3 things are going. These are more important in women because when you have, particularly in women, is when you have the most of these problems is when you have childbirth, because when you have childbirth, these muscles and nerves which supply the rectum, the sling of muscles could be affected as high as 40 to 50%. So women will have dysfunction post pregnancy because of this muscle damage potentially or the nerve damage, and usually it recovers but may become weaker. And as you get older, these muscles and become weak, particularly the anal muscles can also get damaged, and then you have a dysfunction. You could have incontinence, you could have rectocele, you could have multiple problems which we call pelvic floor problems. Now, this is a difficult, challenging area, the pelvic floor problems, because one, people don't know what these symptoms mean, and even it is a challenging problem even for doctors to treat, because one, patients wouldn't know who to go and ask. They could be embarrassed to talk about, look, I can't evacuate, or I'm leaking because when I cough, there's urine leakage, or when sometimes there is stool in the is soiling in the underwear because it just leaks without my knowledge. Now, most of these women usually would have had some trauma, by which I mean injury to the pelvic floor muscles or the anal muscles or the nerves during childbirth, so which has not been recognized, or they would have had an episode where they put a cut to get the baby out. Sometimes the muscles may get damaged, the anal muscles, so or the floor sling muscles itself could be stretched out. So these are challenging issues, yeah, and it could be present in a multiple ways of fecal incontinence. It could have organ prolapse, or where you could have the muscles are weak, so the rectum is prolapsing out, or there is uterus or vaginal prolapse because the sling becomes weak, because it becomes stretched, because of childbirth and injury to these muscles and nerves, as we've discussed. You can also have urine leakage because the muscles are not effective to control, because there is a sphincter or a valve which may again get damaged, and that's when women will have incontinence to coughs, sneeze, or even laughing. So it's an embarrassing symptom, but something can be done about it. We need to investigate it. So typically, this pelvic floor muscles in women particularly called anterior compartment, middle compartment, posterior compartment. Anterior compartment is where it involves the urinary bladder and the urethra. The middle compartment is where the vagina and the uterus, and the posterior compartment is the rectum and the anal muscles, right? So most commonly you will have one or two compartments, sometimes three compartments all involved. So that is why this pelvic floor problems need to be managed by a specialist team, and in a pelvic floor unit where you have colorectal surgeons, gynecologists, and sometimes with urologists, all working together to manage these problems, because it's a common problem but not addressed properly. So we need people to talk about it. We at the Apollo hospitals and also the Chennai Colorectal Clinic, we have special clinics so that patients can reach out, talk, consult. The important thing in these things is to at least know what your condition or what your problem is. Most of the time people just live with it, saying like, yeah, childbirth, I think that's how it is, you would have this damage, and we live with it, because they don't know that's not normal. Two, they don't know who to approach. Three, they might know which doctor to go to. So there are multiple things with it, but the reason I'm bringing this up is because it affects childbirth, affects causes some damage to women's pelvic floor muscles, or some symptoms, 40%, which most of them recover and some may not, and it will show up later. So the important thing is to get this checked. I remember in England we had a protocol where at 4 months all women who post pregnancy used to come for a checkup, where we took a history and we graded them, and then we also, what we did was we did an endo-anal ultrasound, and we did manometry, which to check the pressures of the anal muscles. So once that was all okay, then we reassured them and they felt a lot better. And then if they had symptoms, then we got them investigated and see what can be done. Most of the time you could do away with a little bit of changes in diet and exercises, pelvic floor exercises. But sometimes muscles are torn, and which can be repaired. So those are the options with that. But pelvic floor problems, incontinence, organ prolapse, incomplete evacuation, Another problem is rectocele, which can give you an incomplete evacuation symptom. So you go to the toilet, you feel that it's incomplete. You go second time, third time, you feel pressure uh, in the perineal area. That's the area between the rectum, anus, and the vagina. You feel that, and women particularly have to put their finger into the rectum to evacuate, or sometimes put a finger on the vaginal side to push and evacuate the stool out. And now you would be surprised how many women have that trouble. That's most commonly because they feel that sensation, and some stool is stuck just above the anal canal and anteriorly, where they start to form a rectocele. What we mean by rectocele is a weakness on the anterior rectal wall. So rectum, vagina, as I said, in the pelvic floor area. So this is the rectum and this is the vagina, and the anterior wall becomes weak, and that pushes and forms a shelf where stool sits there and unable to evacuate. So they have to do a finger evacuation. So the problem will be that there will be lots of people who have this trouble. They wouldn't know how embarrassed we talk to ask for help. I think as friends, family, wives, husbands, all of we should educate each other and ask if patients have these symptoms to seek out, because something can be done. And so with rectoceles, if it's a big size, then you investigate further by doing an MR difficogram, which can show this rectocele. Also, it will show if there's any other compartment which is also weak or not supported properly. And so you can do a combined procedure to fix all these things, and patients do really well. Okay, so that's that. Let's see what are the questions. Hi Kongon, thank you for joining in and getting all your friends to watch. So keep asking your questions so that if I miss out any, I will individually answer to you personally on the chat box. So what else will we discuss today? Okay. So one question about dyspepsia or feeling gas, bloated. It's a very common symptom. One of the commonest patients who come to our clinic, or a lot of them have these symptoms, probably of feeling tightness in the chest, or feeling as if there's gas there which is getting stuck. They worry it could be a heart attack. So if you have chest tightness and if it is pain which is acute and on the left side, and it's radiating to the left arm, left jaw, you're sweaty, it could be a heart attack, yes. But most commonly what patients complain about is they're feeling a bit of chest tightness, but when they burp, get the gas out, they feel better, they feel bloated, they're not evacuating properly, brought on by food. That's usually because of gastritis and reflux, most likely a lifestyle thing. It all depends on, as I said, what you eat, what comes out. So it's important to eat healthy. It's once in a while having a snack, eating out, great. Now ordering online has become so easy, so we all tend to, okay, let's try different varieties. See, we have to remember, whatever tastes really good, they would have put in lots of stuff to make it taste good, right? Otherwise we can all cook like 5-star. There are healthy foods as well. All I'm saying is, whatever, you got to be cautious about it, because yes, we would love to have some food which tastes good once in a while, but not 3 times a day. So you need to watch what you eat. You need to eat light. So I there was a time when I was younger, I used to eat full, that too, a plate of biryani, love that. So eat full, and when you're in college, you go hang out with your friends. But what happens as you get older and you want to get fitter is that you want to cut down. Okay, you feel, okay, I've had that feels great, but you don't want to force yourself, because that's when you unnecessarily it doesn't digest well, it stays in tummy. And eating late, but it's a way of life in the subcontinent, because you finish work and then you go out, eat late, come back home, and lie in front of the TV and and go to sleep late. But the problem with these things is, if you ideal times to eat are morning, as I always keep telling you, is to eat breakfast. It's an important thing. I used to avoid it. I had lots of trouble with gastritis and digestion issues. But once I started eating regularly in the mornings. Most of the digestion issues went away. So morning breakfast is one of the most important things which you will do. Please do that. Eat on time. Between 8 and 9 is a very good time to eat. Because that gives you the fuel for the rest of the I remember the days when I rushed to theatre and I don't have anything to eat. I feel so tired. I'm performing an important procedure, so I need to be fresh. I need fuel, right? So similarly, when you're going to work, you need to have your fuel. There's no point skipping breakfast. I would say cut down on your dinner if you want. Cut down. Don't starve, but cut down. But breakfast is very important, and then drinking water 3 liters per day is very, very important. And lunch also, eat on time at 1 o'clock, and then your dinner should be about 7:30, 8 max, and then exercise 45 minutes at least every day. If you want to do an hour, it's great, but every day exercise. Make it a routine, because at the end of the day, fitness is the most important thing. We can work hard, make money. All those things are important, but fitness is very important, and for your lifestyle, eating on time, exercise, and watching what you eat will keep away most of your troubles, particularly gastritis, reflux, and all these things. So there's a question there. Asking about complex anal fistula cancer. So anal fistula can happen, is usually a benign thing. It can be challenging, as I said, but you can also see that as part of a Crohn's disease. Crohn's disease is part of inflammatory bowel disease. Crohn's disease can affect mouth to the anus. Cancer itself can rarely cause fistula. I don't see it. I have seen it, but it rarely causes fistula itself. Can fistula tract turn into a cancer? Not uncommon, but yes, but usually it doesn't. But yes, it can be associated with cancer. It can be associated with Crohn's disease, but it does not per se cause cancer. Okay. So there's a question about constipation. So constipation, again, it's a very common problem. Everybody will have, as I said, if you're an urban population, 40% will have some colorectal problems. Constipation primarily happens because of the diet you eat and how much water you drink. As I keep telling all of you, it's important. We don't realize, this is roughly a bottle, and you need to drink 3 liters. It's not easy. It's hard, but drinking water is vital, and your diet is vital. And if you have a balanced diet, I know when people start exercising, they go on a full protein diet, they go on different keto diets. What I find is I've not tried particular diets, but I've tried to see how to do this. And we as a civilization in the subcontinent, we've grown on rice. So that's how we've evolved. And trying to replace it with any other form, as an evolutionary, as part of our how we've evolved in the subcontinent, it's not going to suit us. It may work, but having a balanced diet is probably the best. Carbohydrate, protein, fat, in a balanced way, eating on time, eating at regular intervals, and eating light is probably going to be the best way forward. A balanced diet, enough vegetables. Yes, you can have meat. Cut the red meat. You can have red meat. Fish is very healthy. Eggs are fine. Everything in balance will solve the problem for you. But important thing is exercise. We underestimate it. Exercise, because it burns the calories, and it's very effective. So I would like all of you to exercise every day. It's very important. And then watch what you eat. These are 2 important things I want to tell you, and I think we've discussed enough of that today. So the other topic which we're going to touch about is specialization. There's lots of questions about why we have to go see a specialist. So if So when I went for my training, so our training was all general surgery. After medical graduation, so I went to England to train, and we had general surgical training and research training in London and then in the southwest of England. And at that point, when you go into higher surgical training, this was 2001, almost 20 years ago. They said, the training board said, look, everything is going to become organ specific. It could be the gullet or the food pipe, the stomach, the colon, rectum. That's one area. So you choose what you're interested in and you get trained in it. So when I asked them, but sir, I may get patients who have problems in the gullet or pancreas or breast, or I'm planning to go back to India training. They said, yeah, you could do what you're qualified to do, but if you want to have a subspecialist interest in dealing with more complex cases, then you need to concentrate in one area. So you would do more numbers of that particular area. It could be fistulas, it could be cancers, but if you're doing a bit of breast, bit of this, you may still do a good job, but that's fine. But not everybody will be able to do it. So if you choose one area of specialization, it's like work. I'll give you a example later, but let me finish this little story. So in the colorectal space, so they said, okay, you can go do that and go do laparoscopy, and then robotics, and then colitis, cancer, advanced, do more numbers of it. So that's what it is. And I asked them one question: what happens if a patient comes to me and has a breast problem? So they said, like, you should call a friend who does, or a colleague who does breast work, and they would probably do only breast. That's how in the UK or US most of the service is built on specialists who do only that. So that way, instead of doing 10 breast surgeries or 10 pancreas surgeries, 10 colon surgeries, they would be doing 30, 50, 100 just colons, or 30, 50, 100 breast operations. So you become really good at that. So that is the difference between specialization. And so there's also research evidence shows that if you are specialized and if you're doing more numbers of that, so for example, we do more than 120 individually colorectal cancers in a year. So what happens is, I will know my patients, what they have, what are the complications related. will have data so that my patients can come and say, oh doc, what is your leak rate, what is your cancer recurrence rate. So we would become better at our jobs, and it's never a stop point in a doctor's work, because you keep learning new things, new techniques. For example, laparoscopy was in the last decade. This year, more robotics. We're doing lots and lots of robotics, and we, and probably the highest numbers in the country now in our the Apollo Main Hospital, where we do this work for colorectal surgery. So we get good at that. We know how to handle it, and patients have a lot of better results because we're doing a lot of this. So that's why specialization comes in. So you have a expertise in a very niche area, and it could be hemorrhoids, piles, fistula, or colorectal cancer. So, for example, so that could be in any job for that matter. Suppose if you are as I often quote, in cricket, so you could be an all-rounder, but there are not many all-rounders. You could have a specialist batsman like Inzamam or Sachin Tendulkar, or because you ask them to bowl, they will take some wickets, but they're not very good at that, right? But if you do it long enough, you will be taking some wickets, bowling, I meant. But you will be good at one particular area. So that is what specialist batsmen and specialist surgeons are. So that's what the difference. So that's what a question which we're trying to answer. So ulcerative colitis. So ulcerative colitis again is part of inflammatory bowel disease. Crohn's disease one side, ulcerative colitis another one. Crohn's disease can affect anywhere from mouth to the anus, as we've discussed previously. Ulcerative colitis typically affects the colon, rectum, starts in the rectum and then affects the colon. Crohn's disease can affect different parts of it. Can skip lesions, one bit normal, one bit abnormal, so it can skip and can affect any. It's more challenging disease to it. Ulcerative colitis typically starts from the rectum and then it goes, to the colon. So causes, again, it's basically the body's response to some sort of trigger, and body sets up an inflammatory process to control, but then the inflammatory process is so severe that it sets off multiple components which react to this attack, and there is an overreaction typically. That's what inflammatory bowel disease is. So usually you can control that with medication. When it's not controlled and causing symptoms, typically in ulcerative colitis, you would see change in bowel habit, loose stools, blood in stools, blood mixed with stools, weight loss, anemia. Then you need to have medical treatment. There is a different medication levels which you can treat. There is top up, going from simple ones to more complex medications, or you can start with complex medications which can modify this response. But the important thing again, diet for this is to just eat healthy. There will be diets which aggravate it. The important thing is to have a balanced diet. Speak to your doctor, speak to your dietitian, and they'll give you advice on that. So that's ulcerative colitis. Surgery for that, if medical treatment fails, if you have lots of stool, like 8, 10 times, 12 times, you've been on steroids to and it hasn't worked, and you're on lots of strong medications, and medications have side effects. So that's the problem. And also, if you have ulcerative colitis more than 10 years, you are at risk of developing colorectal cancer. So it's important to keep that monitored. You have a doctor managing it, and if the symptoms are not settling, and if there is change, and then you need to have your entire colon removed, and then we use the small bowel to make a pouch. All that can be done through keyhole robotic surgery, and we do a lot of that in our service at the Apollo Main Hospital. So so that's about ulcerative colitis. So if there's any more questions, keep punching them in. Follow our YouTube channel, like our page, follow us on Instagram. Pilonidal sinus, I think we've discussed that before too, but typically the pilonidal sinus happens in between the two buttock area. It's away from the anus, but in the buttock area. Typically happens in young men. Hairy young men is when typically it can affect women, but more often in young hairy men. It's basically one of these hair pits gets inflamed. It forms an abscess. And it gets inflamed, and the hair collects in these pits. It can be a nuisance. It can form form an abscess, keep discharging, foul smelling. It's a big nuisance. Simple things to do are, cut your hair, shave that area between the buttocks, keep that area clean, wash it with soap, and if it's a small one, you can remove that through surgery. If you have an abscess, you can retrieve the antibiotics, but if it's a recurrent problem, you need surgery. If it's an extensive, you may need flap surgery. So pilonidal sinus particularly is a problem because it's in that particular space between the buttocks, and can be a real nuisance. Okay, so that's pilonidal sinus. Any other important questions do you have? Please do ask. As I said, this Facebook live sessions are done to educate people, so this is for you. Please keep sharing it with your friends. It's a platform for you to ask questions. If you can privately message me on the Facebook Messenger on the page if you don't want to put it in the group, or you could always do an online consult. There are it's all on our the WhatsApp numbers are there, so please do, and we'll let you know how to have a consultation, video consultation as well. So there are multiple ways. I think that's one of the things which we've done better in this post-pandemic period. We're going to have these consultations all sorted out and set up for our patients. The next thing I would is to just I think the important message always is to not ignore your symptoms. If you have symptoms of rectal bleeding, change in bowel habit, anemia, weight loss for more than 6 weeks, then you need to be investigated. You need to see a doctor. You need to have tests done or consulted, examined. These are very important. 6 weeks. In the interim, if you have any of these symptoms, it's just started, you modify your diet, drink more water, take a laxative if you have constipation. But the important thing is to watch out if these symptoms settle or not. If they don't settle, then you need, for more than 6 weeks present and not getting better, then you should see a doctor, because you could have something simple, but it can also be it's a symptom complex or constant symptoms which signify colorectal cancer. As I've been telling you, colorectal cancer is a huge problem in the subcontinent. Almost 1 lakh cancers happen in the subcontinent every year if you put all 4 countries together. So it is a major problem. We have about 35,000 deaths in India every year with colorectal cancer or more. And the good thing about colorectal cancer is you can screen for it. Colonoscopy is the gold standard, and then and if you find polyps, they can be burned through colonoscopy. So that's why if you have symptoms, mostly if you have a colonoscopy, if it's a polyp, it can be removed or burnt, and that way you could prevent. Basically, you can prevent colorectal cancer by screening, right? Although we don't have a screening program in this country, because the incidence of colorectal cancer is 4 per 100,000 compared to Western world, where the incidence is higher. But the problem as we have is that the patients come, they ignore their symptoms, and they come at a later stage. So that's why the mortality rate is higher. So if you come early with the symptoms, of you diagnose cancer early, you can completely cure them. And we have fantastic treatments available. Surgery, chemotherapy, radiation, these are all work beautifully for colorectal cancer, and can be completely only if you can come early. So if you come late, then it becomes more challenging to treat. So that's something that's very important. So another 5-10 minutes to go. If there's any important questions, please to ask. Okay, there's a question going to the toilet 2 or 3 times and still sometimes feeling burning sensation and itching. So these are very common symptoms. Most likely, it depends on the age. If you are changing bowel habit when you're 60, 70 plus, obviously you need to be screened for colorectal cancer and things. If you're younger, you still need to be screened with this, like a mini half colonoscopy. But most likely that it could have internal hemorrhoids, which are typically cause incomplete evacuation, burning and itching. Sometimes you can have a small fissure which can cause those symptoms. So there are 3 common problems with in the anal region. One is hemorrhoids, which can cause painless rectal bleeding, burning, itching, incomplete evacuation. Pain is not a feature of piles or hemorrhoids. Anal fissure, which is a cut, the anal edge, because of a hard motion, typically comes with tearing pain, like ground glass being applied to it. But you can see drops of blood, but typically not a lot of blood. You can see a little bit of blood, but most common symptom with fissure is a tearing pain, severe pain, and constipation. And anal fistula, when there's an infection in the gland and forms an abscess. Those are 3 common things. But burning sensation, itching could be hemorrhoids or could be a fissure. So that needs to be looked at. Okay. What else questions are there? Okay, diet for fistula patients. Well, there is no particular diet for fistula, because if you have a fistula, you have to lay that open and treat. Surgery is only treatment for anal fistula. Just remember that if you have an abscess, it has to be removed. In anal fissure and hemorrhoids, most common causes is constipation. So you can change that by increasing your water, better diet, lots of vegetables, avoiding red meat. That's a better diet for constipation, which will cause hemorrhoids and fissures. For fistulas, I think standard staple diet, healthy diet is good. So any other questions, please pop it in the box, and we'll talk about. We talked about screening, and also if anybody has colorectal cancer, been treated for colorectal cancer, then say the patient's brothers and sisters need to be screened. If the patient, if your parents, for example, mother or father has that colorectal cancer, then their children need to be screened. If your father has had or a mother has had colorectal cancer, their siblings, their brothers and sisters need to be screened, right? Does that make sense? So if a father is there, or a person is there, he's got colorectal cancer, his brothers and sisters need to be screened, his children need to be screened. It could be the mother as well, and but father has got cancer, the mother doesn't need to be screened, yeah? The wife or the husband doesn't need to be screened, I'm just putting that as a fact. Their children need to be screened because they hand over the genes of this colorectal cancer, so that's important. So there's a question, why am I not coming to Kashmir? I'd love to come. I've never been to Kashmir. I just love what I see in Kashmir. The people are amazing. I've had friends from Kashmir. A very good, good friend, Seema, who she's in the UK. She's from Kashmir, and I'd love to visit. I don't know the language very well, but I'm sure we can learn that. But at least online we could do some consult for patients in Kashmir. I'm happy to help. So we're almost another 5 minutes to go. So if there are any other questions, we will, and we will do. We've done hemorrhoids. We've done fissures. We can do another fistula. We'll do a colitis. We'll do another PowerPoint type thing in the next few weeks about. You can do about colorectal cancer or inflammatory bowel disease. We'll figure that out. I'll put it out for you. Yes, Fiji Islands, of course. I would love to come there. Yes, Anita. So that's been good to connect back, and I think it's good questions today. And eat healthy, stay safe. Don't ignore your symptoms. For as I said, 6 weeks. More than that, have it checked. I will put this video out on YouTube as well. Follow our channel. All these videos will be there, and I will see you in another few weeks. Take care, stay safe, wear your mask, maintain social distance for the next few months. Very important. Bye bye.